going to record this for other members that may not be able to attend today. We'll go ahead and get started and let folks in as they come. Thank you for being with us today for this webinar on the 340B Pharmacy Program. Our speaker today is Colleen Myman. Colleen is the National Policy Advisor for the KPCA, the Kentucky Primary Care Association, and for the 52 state and regional primary care associations in the United States. Prior to starting the role in January 2021, Colleen spent 6 years with the National Association of Community Health Centers as the Director of Regulatory Affairs and Senior Policy Advisor. Previous to that, Colleen spent more than 2 decades in the federal government, including in the HHS Secretary's Office in the U.S. Senate, in CMS, and in numerous positions within HRSA. Her expertise is in the regulatory, administrative, and financing aspects of federal programs such as 340B, Medicaid, Medicare, Section 330, and the ACA, and how they impact community health centers and their medically underserved patients. Colleen, thank you for being with us today, and take it off.
Absolutely. Very happy to be with you here today. What I'd like to do is give you a brief overview of what I consider to be the most confusing and yet important program for supporting the healthcare safety net in the country, the most confusing and important one I've seen in the 30-some years I've been doing federal health policy, and increasingly a program that is coming to the attention of state legislatures, not just the federal legislature. Before I do that, just to do some level setting, that I want to talk briefly about community health centers, also known as federally qualified health centers. For anyone who's not familiar with them, CHCs, as I call them for short, are known as the backbone of the healthcare safety net. They provide primary care, behavioral health care, dental care, lab and radiology services, preventive health care to anybody who shows up, regardless of ability to pay. And unlike a market-based provider that's following market trends, health centers are intentionally located in areas where there are large numbers of medically underserved patients. And their mission is to care for medically underserved patients. So we're in a lot of rural areas. We also serve a largely low-income population. Varies from health center to health center, but roughly 70% of health centers' patients are below the poverty level. Another 20% or so are between 100 and 200% of the poverty level. But two things that make health centers really unique is that we provide care to anybody who shows up, regardless of ability to pay, and we charge them based on a sliding fee scale, based on their income. So no one is ever turned away from a community health center for inability to pay. The other thing is that they are community-based nonprofit organizations. They are managed by their own patients. They are never controlled or owned by some outside big organization like we're seeing increasingly throughout the healthcare sector. And in Kentucky, there are now 31 community health center organizations, and they provide care at 431 locations. Now back to this incredibly complicated but important program, the 340B drug discount program. I'm going to talk a little bit about the basics of the program, including how it operates and generates savings, which is often a source of confusion. Some of the big issues, particularly those that are coming to the attention of state legislators, and we'll have some time for Q&A. In terms of program, just basics of the program, you have to admit that 340B has about the worst name out there for a safety net support program. It's actually a program that doesn't have an official title, so we refer to it by the section of the Public Health Service Act that created it. And this program has been around now for 32 years. It was created in 1992. And in short, the 340B program requires drug manufacturers to sell drugs at a discounted price to certain safety net providers, ones who care for a large share of underserved populations. So the manufacturers have to sell drugs at a discounted price to certain safety net providers as a condition of being approved to get their drugs covered under Medicaid and Medicare. So a key point to note here is that the 340B discounts we'll be talking about throughout this presentation are funded entirely by drug makers. They're discounts that the drug makers have chosen to offer in order to have access to these other markets. They are not funded by taxpayers. The cost to taxpayers is very minimal. There's a very small staff within HHS that oversees the program. That's the only cost to taxpayers in this program. So when we talk about eligible safety net providers, and by the way, the official government speak for eligible safety net providers is covered entities, in case you ever hear that term. The eligible covered entities are largely hospitals. Hospitals that with a high disproportionate share of Medicaid and Medicare patients. Also, small rural hospitals, the critical access and small community hospitals, and also very focused hospitals like Children's Hospital, cancer hospitals. Hospitals account for about 85% of purchases under the 340B program. So they're definitely the 800 or 850-pound gorilla in the 340B program. Then you also have the little guys, the grantees, who are providers who get HHS grants to serve as safety net providers. This includes community health centers, Ryan White clinics, and a lot of very disease-specific programs like hemophilia clinics, family planning clinics, STD clinics, age drug assistance programs, etc. We're small potatoes. All those grantees put together are only 15% of the program, but we're there. And it's important, I think, that we not be forgotten because we tend to be collateral damage in the war between the hospitals and pharma. So the next question is, okay, manufacturers agree to offer a discount. How big of a discount do they have to offer? Well, there is a basic discount they have to offer. If it's a brand name drug, they have to give you 23.1% off of the sticker price. And the sticker price is not publicly available. Pharma keeps those prices very closely hidden, but HHS has ways of estimating them. So it's 23.1% off the estimated sticker price of a brand name drug, 13.1% off the price of a generic drug. That is all that manufacturers are required to provide in terms of a discount. All that's out of their control. But there is a second type of discount that may apply to certain 340B drugs. And in recent years, we've seen a lot of this. If a manufacturer raises the sticker price of a drug faster than inflation, then there's an additional discount that kicks in, and called an inflationary discount. And there are multiple circumstances in recent years where the price of the drug has risen so quickly, the sticker price of the drug, that additional discount has more than offset the entire price of the drug. Okay? This was a provision that Congress put in years ago to try to discourage drug manufacturers from raising prices faster than inflation. Clearly, it didn't work very well. But that's why you will hear drug manufacturers talking about having to give really big discounts above 23.1% on 340B drugs. Those larger discounts are a direct result of their decision to raise prices faster than inflation. They want to reduce those discounts, they can slow down how fast they raise drug prices. So why was 340B created back in the first Bush administration to begin with? Well, back then, without 340B, many small safety net providers were forced to pay the sticker price. It was sort of like going for a car. You had to pay the sticker price. Now, we all know that nobody who's a good negotiator, who has any sort of market power, pays sticker price. So little CHCs and small rural hospitals were paying sticker price, but these large health systems were coming through and they were able to negotiate big discounts. And we were starting to see pharmaceutical benefit manufacturers, and they were able to negotiate these giant discounts. But these smaller community-based organizations that focused on the safety net were stuck paying the sticker price because they lacked the market power to get any discounts on their own. That left health centers and others spending a whole lot more on drugs than other types of providers did. And as a result, prior to the creation of 340B, Many of these providers, including almost every health center in the country, we just couldn't afford to provide pharmaceuticals at all. We lost way too much money by having to pay sticker price for these drugs and then having to offer them to low-income patients at a price they could afford, which is the legal and mission requirement for us. So recognizing this, Congress came along in 1992 and they created the program, and they put the intent of the program actually in the report that accompanied the law, not in the law itself. But the language, the program's purpose, according to the report, is to enable these safety net providers to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. And the way health centers have read that for 30 plus years is to stretch scarce federal resources as far as possible. In other words, to not pay sticker price for these drugs to actually get the discounts similar to what other providers can often get. Okay. And then to take that money and put it back into funding services, other services that are needed by your underserved populations. So there's two key points I'd like to highlight here. First of all, Congress, when creating the program, intended the benefit of 340B to support the safety net providers directly, rather than the patients. This was not a drug discount program for patients, like a patient can go buy a drug at an X% discount. This was a way of helping safety net providers spend less on drugs so that they could take that money they would have spent on drugs and use it to provide other services. So in no way am I saying that patients don't benefit from 340B. I'm just saying that it is indirect rather than a direct discount on the drugs. Often it is, but it's not always a direct discount on the drugs. What 340B really is about then is it's about much more than pharmaceuticals. This is much more than a drug program, because by helping health centers and others free up funding, then that funding can be used to support a whole bunch of other services for the medically underserved populations that they care for. So for instance, let's talk about Kentucky, but I want to be clear that health centers and the other grantees are required by law and by federal regulation to take every penny of 340B savings and invest it into services that expand access for the medically underserved patients. Now, just to be clear, this language does not currently apply to hospitals just because it actually comes through our grant rules as opposed to the 340B rule. So you'll hear some discussion about that. I am not saying that hospitals do not invest every penny into expanding access for underserved populations, but the legal, statutory, and regulatory requirements apply to all grantees. And in Kentucky, I'd like to give you some examples of what Kentucky health centers do with their 340B savings. They use them to cover the costs that they can't otherwise cover for things like dental care, school-based primary care, transportation services, vision services, other types of services that patients need. So by freeing up funds over here, and I'll talk a little more about how we get those funds, you use them to pay for these other services over here. So yes, the underserved patients continue to benefit. It's just not necessarily a direct discount on a drug. One final point before I get into the mechanics. It is not an overstatement to say that 340B is essential to the financial stability of many safety net providers. And I know you probably hear that term from a lot of places, but I'm going to give you some data to back up that statement. For instance, community health centers generally get federal grants. On average, 340B contributes more to a health center's bottom line than their federal grant does. Okay. Also, I would encourage you to speak to any critical access hospital or sole community hospital in your district. I bet they will tell you that they could not keep their doors open if they lost 340B and those savings. We've seen a lot of attacks on the program in the last few years, and as a result, we have seen health centers across the country scaling back services and laying off staff because when 340B savings go away, so do services for underserved populations. In terms of how 340B operates, how it generates savings, I'm just going to refer to a flow chart here. This is a very simplified example. And its flow chart's kind of in 2 pages, the best I could do to fit it in here on a slide. Let's say you have a drug whose regular price is $100. And under 340B, the health center buys the drug at a discounted price of $70. So we got a $30 discount. We have it shipped to either a health center owned pharmacy, because we can own our own, or if we don't have the ability to have enough of our own pharmacies, we have it shipped to a contract pharmacy. One of those pharmacies, either of those pharmacies can dispense those drugs to either insured patients, and that's box number 5 over here, or to uninsured patients. First, let's talk about the insured patient. The insurance company pays us back $100 because that's the sticker price. We paid $70 for it. That means the health center comes out $30 ahead. Okay, just want to go back over that. We pay $70 for it. The insurance company reimburses us $100. We come out $30 ahead. So far, so good. Now let's look on the other side. Let's say that in-house pharmacy or contract pharmacy sells the drug to an uninsured patient. That uninsured patient most likely is their income is not such that they can afford to pay the $70 price. So we put it on a sliding fee scale and we sell it to them for $20. That means the health center paid $70 for the drug and we got $20 back from the patient. We are short now $50. Okay, that's this box number here, number 10. Well, then you put all of this together, the drug provided to insured patients and uninsured patients. Let's say you had 3 insured patients who got this drug and you cleared $30 in savings on each of them. That's $90. And you have 1 uninsured patient. Well, what do you do with that $90? You take $50 of it, and that offsets the cost to be able to make that drug affordable for the uninsured patient. That fills in the $50 gap for dispensing that to the uninsured patient. But you still have $40 left over. That $40 is what funds the other activities that 340B supports, school-based state treatment, a lot of behavioral SUD treatment these days, a lot of dental services. So please feel free to stop me anytime if you have any questions with any of this. But now, you may recall that in this flow chart, I mentioned that the drug could be dispensed by either a pharmacy the health center owns or a contract pharmacy. That means a pharmacy owned by an outside organization. It could be a small mom and pop. It could be a big chain like a Walmart or something. Sometimes we use those to dispense our drugs. For health centers, 70% of the drugs that we dispense go through contract pharmacies. The reason for that is, and I don't think I need to explain this to people who understand the roads of Kentucky much better than I do, contract health centers are in a few places and they can't afford to put pharmacies and staff pharmacies and have all the security in all the places they are. And there aren't even that many places where they provide care anyway, where they can have locations. So by using contract pharmacies, it makes it a lot easier for patients to access drugs closer to home. They don't have to drive all the way to one of the care sites where the health center is able to have an in-house pharmacy. There are a lot of health centers that don't own any of their own pharmacies at all. They can't handle the staffing, the security, all of that is too heavy a lift based on their financial situation. So contract pharmacies fill in for that. Also, to be clear, a lot of drugs now are only available through specialty pharmacies, which are contract pharmacies. That's why another reason why contract pharmacies are so important to community health centers and also to other 340B providers. Okay. Just as an example, Cumberland Family Medical Centers, okay, that's their service area there. They've got most of the middle of the state. They don't own any of their pharmacies. If it weren't for contract pharmacies, there would be no way for their patients to be able to get to affordably priced drugs. And let's just say, and I'll get to this in a minute, there are some manufacturers who are saying, okay, Cumberland Family Medical Centers, you can have one contract pharmacy location, one. So Cumberland, let's say, chooses that in the dead center of their service area. How far is the driving distance for patients who need to get from the outskirts of their service area into that one contract pharmacy to be able to get a drug, be able to get the affordable drug? That leads us to some of the current 340B issues. And I'm really focusing right now on the ones that I consider to be active issues where states are getting involved. Okay. The first one is, as I already mentioned, ban on contract pharmacies. Okay. As of last week, 37 manufacturers, drug manufacturers, and we're talking big ones like Eli Lilly and Johnson & Johnson and Bristol Myers Squibb, have said to hospitals, okay, if you own any of your pharmacies, you're not allowed contract pharmacies. And if you have none, then you get one contract pharmacy. And we don't care how big your service area is or how far your patients have to drive and what conditions, you get one contract pharmacy. Those rules now apply to 23 manufacturers apply those rules to health centers now. So back in that example of Cumberland Family Health Centers, people have to drive to that one location to be able to pick up their affordable drugs. So what is the result of these restrictions? People go a long way to get their drugs, if they can get them at all, or they go without. The other thing that happens is that's for the lower income patients who are relying on the 340B discount. But also, it makes it much less likely that an insured patient is going to go to a place where the health center can retain the 340B savings. And remember, those 340B savings are necessary if we're going to be able to offset the losses to make drugs affordable for uninsured patients and fund so many of these other activities that are critical to meeting the needs of safety net populations. Another issue you may hear a lot about is transparency. I do think there is a bit of an overstatement on the part of drug manufacturers about this. Remember, we're talking drug manufacturers who don't make their own prices transparent. But I want to be clear that HRSA, that is the part of HHS that oversees the 340B program, does regular audits, a couple hundred every year, on covered entities to ensure compliance. Okay. Also for health centers, we have a 98-page manual to make sure, and every 3-year audits to make sure we're compliant with things. What there is lacking right now, though, is a single standardized system for 340B providers to explain what they use the savings for. And as a result, there are people who will say, oh, they use it to, I don't know, send their boards to Tahiti or something. So I want to be clear, not that health centers are begging for any more reporting requirements, because we've got plenty to go right now, but we're not opposed to transparency requirements. They just need to be clear that they tell the whole story. We need to be allowed to say how we use the savings, so it just doesn't look like a slush fund we use for whatever. We need to be able to talk about our operating cost. They can't be overly burdensome, et cetera. PBMs can't use that data to take our savings away from us, which has been a long-term issue. Finally, related to that, these issues have really, and related issues around 340B have really been bubbling up more and more in, I'd say, the past 5 years. Okay. Congress has started holding hearings, they're having working groups, there's draft bills, etc. But the bottom line is Congress still can't seem to get its act together to step in. And so what we are seeing now is that states are increasingly stepping in to fill the gap due to congressional inability to basically get this done. On the left, we see a map of over 30 states, including Kentucky. These are states that have already passed laws around 340B that basically says, hey, pharmaceutical benefit manufacturers, PBMs, you can't take those 340B savings for yourself. They were meant to support the safety net. You can't force the health center to tell you they paid only $70 for that drug, so you pay them only $70 and you get to keep the savings, PBM. 30 some states have already passed laws like that. Increasingly now, in the past 2 years, 3 years, the focus has moved to states banning the contract pharmacy restrictions because they are aware of the extent to which they are hurting not just the safety net providers, but more importantly, the patients that they serve. As of right now, we have 8 states, many of them being pretty blue states, I mean, West Virginia, Mississippi, Missouri, that have passed laws banning contract pharmacy restrictions. These laws have been taken all the way to the Supreme Court and been upheld. So I expect next year that we will see at least 20 other states, at least, that will look to move to ban these contract pharmacy restrictions because they understand the impact that they are having. One statistic I might have skipped over somewhere. I was in Iowa recently and I met with the 8 health centers in Iowa, and people in Iowa tend to be pretty understated. I said something about the impact of contract pharmacy restrictions, and all 8 of them were around the table, and one of them looked at me and said, 6 out of 8 of us have already laid off staff so far this year because the manufacturers' unilateral contract pharmacy restrictions are costing us so much and forcing us to shut down so many services. So those are the reasons why states are really starting to step in on these sorts of bills. In fact, you had a bill last year that made it through one chamber, if I remember correctly. So finally, I'd like to leave a few minutes for Q&A. And also here is a slide that summarizes the key points from this presentation in case you might find that helpful. So any questions for me? Or Chuck, anything I missed?
Colleen, before, if they have any questions, the participants here, could you explain just briefly how pharmaceutical companies, since 92, pharmaceutical companies were shipping to contract pharmacies, CVS, Walgreens, mom and pop independent pharmacies, Walmart, Kroger, anywhere. And then about 3 or 4 years ago, they started these restrictions. Can you explain kind of in the federal statute, what's there, what's not there, and what their justification has been?
Their justification is that there is nothing in the federal statute that explicitly says the words contract pharmacy. And so the manufacturers are saying the statute does not require us to ship to contract pharmacies, and therefore we will not. And they started this, Eli Lilly started this back in the summer of 2020. There are more court cases circulating around that federal law than I honestly can keep track of right now. So there has not been a definitive resolution from the courts about that. And I don't think we're going to see a definitive resolution anytime soon. But they've just said, it's not in the law. We don't think we have to do it. HRSA has come back very strongly and said, the law says you have to sell to the covered entity, and wherever the covered entity or the safety net provider wants to send them to is the safety net provider's business, not yours, manufacturer, to which the manufacturers have simply just gone to court and filed multiple lawsuits in multiple different districts. So the agency is really tied up in court battling all those lawsuits right now. And meanwhile, more manufacturers keep piling on because if you don't have contract pharmacies, you don't have to offer so many discounts, and that's a better financial deal from their perspective.
For sure. And just one other thing, and then I'll shut up. But the contract pharmacy restriction bills, the ones that we're most familiar with that get the most publicity are the states of Arkansas and Louisiana. I think we've seen that 10 to 12 pharmaceutical manufacturers, since those laws have been enacted in Arkansas and Louisiana, have begun shipments again to contract pharmacies. And there have been lawsuits from pharma against the states that have enacted these pieces of legislation. But can you speak to how those those appeals
Yes,
suits have
pharma,
gone?
and by pharma, I don't mean just the trade association. I also mean Eli Lilly and AstraZeneca, the individual companies. The manufacturers have lost every single one of the suits about the state legislation, including appealing to the Supreme Court to have the state laws overturned and having the Supreme Court saying, no, we're not getting involved. That was a unanimous decision by the circuit court. We're not getting involved. And just to be clear, Chuck, in Arkansas, where there are 30, they had the first law, 37 manufacturers, 36 of them have now backed off. So for health centers and other providers in Arkansas, contract pharmacy restrictions are a thing in the rearview mirror, except for the manufacturer AstraZeneca, who is very determined to just keep suing. And they have multiple lawsuits going about Arkansas in particular right now.
Thank you, Colleen. Anything from the participants? Any questions? Anything? Everything's on the table.
Hey guys, I'm so sorry I'm late. I have really had trouble signing in. So this is my question. I think you just answered it. If we could get the House to pass the bill that we passed in the Senate last year, you think it would stand judicial review?
Yes, I think that pharma seems to have a plethora of lawyers. By pharma, I mean the individual companies as well. I'm not saying they won't sue you anyway, but the Arkansas law was written on the back of an envelope in a closed room in 45 minutes. It's not the strong law anybody would have written, but even it has stood up against multiple challenges at the district court level, at the circuit court level, and just yesterday, the Supreme Court refused to hear it. Louisiana law has been upheld multiple times. Mississippi and Maryland, the manufacturers tried to get the laws blocked. They've been rejected. Manufacturers have not won a single lawsuit about state laws, not one.
And the bill as we wrote, which basically said if you give it to somebody else, you got to give it to us. That works? That covers it?
I will need to take a quick look at it, and we've learned a little bit. There may be one or two words that we want to add just based on recent experience, but I remember thinking your bill last year looked really good.
Awesome.
But it doesn't mean we haven't just learned something. Oh, let's close this loophole.
Yeah. Well, we had bipartisan support in the Senate. I mean, without question. I mean, it was a Republican supported bill and it went through. So all we have to do, I think, is, God willing, to talk to the people in the House and let them know what it is we're actually talking about here, how much this impacts our more rural healthcare centers. Some of our urban, but mostly our rural. Thank you.
Absolutely. I mean, I wonder, you look at those driving distances and they're amazing. And then you figure you've got to get car issues, you've got weather issues, people just aren't getting their meds, period. And other services are being shut down. And it is a very compelling and I would think pretty clear-cut argument.
If I may, can you guys hear me?
Yes.
Okay, good. So I was a co-sponsor over in the House and unfortunately, obviously did not get through over there. So I think one of the concerns that has been expressed, and I think you addressed it pretty well early on in your slides here, is what are the savings being used for? And I think that's one of the larger questions that folks have. It's not a slush fund for trips for board members. It's the savings is used to provide, other services to an underserved community. So I think if we can dispel some of those concerns, I think that would help. I think another concern that I've heard expressed by some other House members is why would we, the state, want to get involved when this is something that should be addressed by the federal government? And I don't agree with that mentality, because obviously this is something that our U.S. senators and congressmen are aware of, but yet nothing has happened to fix this situation. So it's left for us to do something about it. But I think that's another one of the questions that some of the House members have had. And so I think if we can, illustrate to them the fact that we could be waiting quite a while for anything to happen to fix these issues. And by that point in time, our community health centers and our rural community hospitals are losing millions of dollars. I recently sat down with the CEO at TJ Sampson Community Hospital, Neil Thornberry, over in Barron County, and he illustrated to me what the loss and the savings has been like for them at that hospital, and obviously stressed his concerns about, if this continues, what are we going to have to stop providing? What types of services are we going to have to stop providing if we can't, get these savings? And I think that's their, I don't recall um, Neil commenting so much on the contract pharmacies, like I guess maybe you guys have. And that was a question I had wrote down. Is there any difference in what the community health centers have concerns about versus what the hospitals have concerns about, or are the concerns mutual?
I would say the concerns are mutual, but the relative weight that we put on them is a little different.
Okay.
For community health centers, 70% of our drugs get run through contract pharmacies. For hospitals, it's 20%.
Okay.
And so while it's important, it's less important. For hospitals, you will see things like oncology drugs and drugs that they can administer on site. Threats to those drugs are the ones that are most concerning for them, because that proportionately is a larger share of their drugs and where their savings come from. The other difference is, and as I said, I am not casting any aspersions on any hospitals, but health centers and the other grantees can point to the law, point to the regulation that says we must invest every penny back into expanding access.
Mhm.
Hospitals don't have that legal requirement anywhere, which makes them vulnerable to claims that they're not using it that way. There's questions about whether or not all of them are. I'm not a hospital person. I can't get in the middle of that. But so those are, I would say, kind of the two big differences.
Okay. Well, and that's unfortunate that there's not a requirement for them to illustrate that. But I think that, and this is what I shared with Neil Thornberry, I think that if we're going to, introduce this in the House, then we've got to do a good job on letting our representatives know how their local hospitals are using these savings. And, some hospitals may be better prepared to give those answers than others, but I think it's important that, like in my district, I have 4 counties. 3 of my 4 counties have small rural community hospitals. And so I have asked that they give me some information that can show what they're using those savings for,
Mm-hmm.
so that when I'm speaking to people about it, I can assure them that, these savings aren't, increasing wages for the CEO and, the admin people at the top of the food chain, but it's going for health fairs and, the cost of like the oncology drugs that you mentioned and things like that that our hospitals are providing to people. So I do appreciate you comparing and contrasting the two, so that I have a better understanding of what it means for you guys. Going back to your slide that shows Cumberland Family Medical and their service area,
Mm-hmm.
are they currently limited right now? You talked about.
Oh, yes.
Okay.
Yes,
Yep.
they are.
So for
Can I share
Eli
just?
Lilly drugs, they have one pharmacy in that entire service area, one
So
physical location.
I have, all 4 of my counties are blue down there: Metcalfe, Adair, Cumberland, and Monroe. So if I've got a constituent in Monroe County that needs an Eli Lilly drug, where are they having to drive to? Do you have any idea?
Russell Springs.
Wow, that's a
Yeah.
haul.
So I've got one patient story that I want to share with the group because I think it's really important, and it's down in the weeds. So my wife is a nurse practitioner for Cumberland Family, specifically here in Russell County where I live. And she calls me about a month and a half ago, and she said, I've got this patient that's got diabetes, hypertension, COPD, all this stuff. And she came in and said, my drugs used to be $35 a month, and I went to the drugstore and they said it's $340. She, the patient came back to her as a provider and said, I can't afford $340. What's going on? My wife calls me. She said, what's the deal? I said, well, what's going on is 340B drugs are no longer available for that patient at the pharmacy that they go to. So they're getting retail charges and they can't afford it. So what's happening is we've got those patients that are uninsured or are on a sliding fee scale that can't get their medications at a discounted rate anymore because of these contract pharmacy restrictions by pharma. So they're going without their meds. They're going to end up in the emergency room, end up in the
Yes.
intensive care unit, and it's going to cost the entire health system a lot of money, and it's going to make people sick. So, I mean, that's one patient at one community health center in Kentucky, and that was 2 months ago. And as far as I know, they probably still don't have an ability to get their medications.
Yeah. So the bill that was introduced in the Senate last session, was there a piece in that bill that addressed this problem?
Yeah, so the bill that Senator Meredith introduced and Wade Williams introduced a companion in the House too. But it was a bill that just said if any, it kind of was trying to eliminate any lawsuits against the Kentucky GA by mimicking the laws that have been enacted in Arkansas and Louisiana. It said if a medication is available at a 340B price or at a discounted price in any other state, that same discounted price has to be offered to providers and pharmacies in Kentucky. The only thing that we really had any issue with, and I talked to Jim Musser over at the KHA about this, is we didn't feel like the enforcement language through the Attorney General's office was quite strong enough in their bill, but I think they had done some background work on it and felt like that was the only bill that they could possibly get rolling.
Okay.
But yeah, the bill that they used in Senate Bill 27 and in Wade Williams' bill too in the House, the language is very, very similar. If a pharmaceutical company offers a medication at a discounted rate in any other state, they have to offer the same discount to providers and pharmacies in Kentucky.
Regardless of what pharmacy the patient goes to?
Yeah, I think it was pretty clear. I think it was
Okay.
pretty clear in the language. The only thing, like I say, that we had any reservations about was the enforcement language at the end of the bill said that someone may file a complaint with the Attorney General's office and the Attorney General may take action. So leaving that may, you guys know the terminology, leaving that may availability in there would also allow the Attorney General's office not to take action if they didn't see that it was appropriate or if they just didn't want to.
So going into this next session, if a bill is filed, does, can it mirror the bill from this last session, or are there things that you guys feel like need to be tweaked?
We're going to work with, I think we're going to work with the KHA, and they've got some members that they've been talking with. I think maybe one of you or both of you, I'm not sure. But they've got some members they've been talking with, but we're going to try to collaborate and get something that's best for both parties and that will have the best enforcement action and get these medications back where they're supposed to be going.
Good, good. I was hoping that's what you would say. So great.
And if I could add one piece, I'm not saying to add it, but just to consider, if you're getting a lot of pushback about use of savings, as I said, it's not like we're asking to sign up for more reporting requirements. But one thing you could consider would be to say, okay, you got to, if we're going to do this, but you need to tell us what you're doing with the savings. I just want to be very clear that when it comes to these sort of reporting requirements, the devil is very much in the details. We have states where they're just saying, tell us how much 340B savings you have. And then the state goes like this. And they don't count how much it costs to run that program, what we're doing with that with those savings, et cetera. So if you get to that point, we'd be happy to help a little bit to think through how to structure requirements around the use of savings in a way that tells the full story and doesn't just lean into one particular perspective.
I don't think I have any other questions at this time. I appreciate you guys doing this. It was very informative. Like I said, I've already been talking with my local hospital and had heard their perspective on this. So it was nice to hear your all's perspective on it as well. I don't know a whole lot about community health centers, although it looks like they're creeping over into my neck of the woods. So hopefully I'll get more acquainted with those folks and learn a little bit more about how they work. But again, I do appreciate you all educating us on this.
Absolutely. One more fact that just occurred to me: when you get pushback around the Fed should be doing this, we're waiting on the final details, but all indications are that this Congress, the 2023-2024 Congress, will go down in history as the least productive Congress in the modern era. Anybody who's waiting for Congress to move on something needs to have an extremely large amount of patience.
And that's actually what I wanted to jump in and say on the Senate side. That argument held sway that yes, this should be done by the federal government. And they actually have the legislation written, but it will not move. This Congress has been the least effective Congress in the history of the United States of America. And that includes apparently a Congress that only met for like 60 days once, I mean, it is really amazing how little work they've been able to get through. And that's why the states are having to pick up both this and prior auths, which should be dealt with on a federal level, but is not being. And in the meantime, we cannot afford to let our healthcare delivery systems go under because they're not doing their job. We have to step in and do something, at least until they pick it up. And that argument worked. People understood it.
We certainly appreciate everyone attending today, and we can make the video available to any of your colleagues. If you've got any colleagues that would like to watch this back that weren't able to make it today, we'll be happy to send that out. And I'll also send a copy of the slides
to me.
Yeah, absolutely. And I'll also send a copy of the slides out to you ladies, and we really appreciate you attending today. Thank you very much.
I so apologize for being late. I really had trouble logging in, but good to go. Thank you. And yes, I would like a copy. Yes.
We'll send it out. Thank you very much for being here.
All right. Goodbye, guys.
Thank you.
Take care.
Thanks, guys.